Thank you all so much for coming tonight to our talk on blood transfusions. So just going over a bit what's going to occur today. So for many of you who have come before, you would know we have the lovely Tass here who will talk a bit about blood transfusions and he'll be asking you questions and getting you to interact throughout the talk. Just before we begin, I'd just like to thank our sponsor, MDMA National. They're currently running two promotions. So if you're a medical student, this year, please, make sure to sign up and there you could go in the draw to win a MacBook Pro. One of the other promotions that they're currently running, if you're an intern, is they've got a intern ready pack specially designed to kind of help you look at the issues and a bit of information as well. So please do make sure to check that out as well. I'll pop the survey link into the chat so you can have a look throughout the talk and provide feedback. But we'd really appreciate your feedback so we can make these talks better and better. But without further ado, I'll hand over to Taz. Thank you so much.
All right. Give me a sec while I share. That feels like it should be working. I
Yep.
presume it's working. Cool.
Yep, we can see
All
that.
right.
Thank you so much.
Just going to get the chat up. I'll ask occasional questions, but mostly mostly I'll just talk about stuff. And you're very welcome to chuck questions in the chat, and I will answer them if I can. All right. So my name's Tass. I'm a haematologist. I work in Melbourne, mostly in general medicine, but a little bit of haematology. So I've given a couple of other talks. Mostly they were more on malignant stuff. So on this occasion, I'm going to be covering a couple of topics that Michelle asked for. And if it looks like I'm staring into the distance, it's because I'm looking at my desktop. So these are the things that I'm going to cover. I'm going to cover basics of blood products, massive transfusion, transfusion reactions, and bleeding on anticoagulants. And then I'll finish up with some cases where you can be interactive in the chat if you would like. And I'm just going to go from first principles. The audience, I'm expecting to be a mixture of levels of experience. So some of the stuff will be probably too simple, and some of the stuff will be probably too complicated for various different people. But a group and hold is effectively an antibody typing. So a red cell typing plus an antibody screen. That's what a group and hold is. And the specific question is both what the type is and whether there are any alloantibodies, so antibodies against human red cells. That's why it's important to give a history of previous transfusion, obstetric history, and known antibodies, if you actually know it. And the reason for that is because your antibodies can wane over time. So if they know that you've got a history of a certain antibody, they will still give you appropriate blood matched so that you won't react with it, even if when they do the actual typing an antibody screen, the antibody isn't present, because it'll recrudesce and you'll get delayed hemolysis. It specifically refers to ABO typing and rhesus. There's lots of other typings, and there's something that are relevant if you're sort of getting extended match blood or complicated to match. And then the cross match is where you actually want to sort of identify some specific units for transfusion to a specific person. If it's a really simple one, they can do it electronically where they just match a thing and don't necessarily check it. But they can also mix the patient plasma with the donor cells to check that they don't react if they need to. Just some facts about the actual products themselves, not every single product, but the most common ones. So red blood cells, and all of this applies to adults. there obviously you can transfuse children and neonates and even do intrauterine transfusions. However, all of these numbers are as it relates to adults, and all of them are like plus or minus X number of mils. But a pack of red blood cells is about 260 mils of fluid. You get about 10 grams per litre increment per unit. And the default, so they don't even tell you this, but the default position is that it's leukodepleted. What that means is just when they, after the blood's been donated, as they're separating it out, they run it through a filter, and that filter filters out the white blood cells of the person who is donating the blood, because the source of a febrile reaction is your body reacting, or the receiver's body reacting to the donor's white cells that have that are present in the transfusion. So before universal leukodepletion, febrile non-hemolytic transfusion reactions were way more common than they are now. The variants that you'll see, there are a couple of other variants as well, but I wouldn't worry about them too much. But you may, if you're in a hospital that does lots of transfusions, in particular for people with thalassemia, historically, some of them got washed red cells, even without a history of really severe allergy or anaphylaxis. The idea is that you kind of wash out the antigens or the antibodies that someone would be having a severe allergic reaction to. It's a huge pain for the blood service to actually do it, and so they cracked down on it in the last decade or so, and you really need to properly qualify for it to get it. CMV negative is mostly around pregnancy and neonate stuff, just to stop neonates getting CMV, and then irradiated blood products. So they're for people where you want to stop something called transfusion-associated graft versus host disease, which is where someone's so immunosuppressed that the T cells in the donated blood go into the receiver, and the T cells proliferate and then attack the person, just like you would get any sort of graft versus host disease. It's very rare, but it's universally fatal when it occurs. And so there's a whole bunch of different categories of people, but you can pretty much think of it as being extremely heavily T cell immunosuppressed. Those group of people need to have irradiated blood products. And then phenotyped is where they've done an extended matching. And they've gotten blood that's not just matched for ABO and rhesus, but also matched for like Kell and Duffy and a whole bunch of other antigen systems that I won't go into because it is time-consuming and boring. So platelets are about 200 mils, and the default is pooled, so where they get multiple donors and pool all of their platelets together, and you give it in a pack. So and you get about a 30-point increment per. I will answer that question in a second after I finish this. So you get about a 30-point increment per unit of pooled platelets. If someone, when they receive a pooled platelet transfusion, and this is usually or almost exclusively in the setting of heavily transfused, like hematology patients with bone marrow failure, so like MDS, or multiply treated AML, who's like been through a bunch of lines of treatment and has required a bunch of platelet transfusions, that style of patient, they can develop what's called platelet refractoriness, where when you give them the platelets, they don't increment properly. And the way that you demonstrate that is you take a platelet count before the transfusion and directly after the transfusion. If they don't increment appropriately, you can apply for apheresis platelets, where they get it from one donor rather than from multiple donors, and they see if they increment to that. And if they don't increment to that, then you can apply for HLA matched platelets, where they get a specific person to come in and donate platelets who is HLA matched for the person. Again, it's a whole rigmarole, and you've got to apply to the blood service, to Lifeblood to do it. They've got a form on their website. Anyone who's worked in hematology for a long time will have at least heard of this happening, but it's not super common. So there was a question in the chat saying, how much potassium would you expect in 1 unit of packed red blood cells? If you had a person with borderline hyperkalemia and they qualified for a transfusion, what level would I be concerned about? I don't think it would make a difference to what I would do, to be honest with you. There's not a significant amount of potassium in the red blood cells themselves. It would only be if they hemolyze. So I would just treat them like any other person, where if their potassium's high enough where you need to do something about it, I would do something about it. It would be very weird for a person to both simultaneously desperately need red blood cells right now and also have a very dangerous potassium level. That would be like an uncommon combination to have, because to desperately need sort of red blood cells right now, you kind of need to be bleeding to death. And it's not that common for that group of patients to have a very high potassium. So hopefully that answers your question. Fresh frozen plasma is the plasma section. So when they take blood, they get the whole blood, they basically spin it in a centrifuge. One side is the plasma, one side is the red blood cells, and in the middle is what's called the buffy coat with the platelets. So it's like the white blood cells and the platelets. So the fresh frozen plasma is one side of it. And that contains all of the coagulation factors. They then go through a process of like freezing it and then defrosting it. And the thing that precipitates out when they do that is called cryoprecipitate. And that contains factor 8, fibrinogen, 13, von Willebrand's factor, and fibronectin. The actual use case for cryoprecipitate is almost exclusively replacing fibrinogen, although if you live in a place where they don't have the purified factor, von Willebrand's factor, you can give people cryoprecipitate if they've got von Willebrand's disease and it's a complete, and they're bleeding or whatever, and you don't have access to the purified blood product. But that's a very niche bit of knowledge. But it should logically follow that if it's got von Willebrand factor in it, you could theoretically use it for someone who's got a deficiency of von Willebrand's factor. But FFP you're using if you want to give someone plasma, so plasma plus all of the stuff in plasma. Cryoprecipitate you're giving to people if they need the stuff specifically in cryoprecipitate, which is, as I said, almost exclusively fibrinogen. And then there's a bunch of other blood products which you'd only really see if you work in specialized areas. Obviously, you all will have heard of and seen and maybe even prescribed IVIG. Subcut immunoglobulin is something that you qualify for more if you've got the like an inborn error of immunity type stuff, which is much more convenient because you can deliver it at home. And then there's specific immunoglobulins for things like CMV, or if you can give something called normal human immunoglobulin for people who've got like measles exposures who aren't immunized and stuff like that. So all of those are run through the blood service. And you've also got the factor concentrates of various types. So factor 8 and factor 9 are recombinant factors that are important to understand if you work in a place where you've got exposure to people who have congenital hemophilia. Okay, so in terms of who you would give which blood product, and I've got another couple of slides that sort of specifically go through some of the cutoffs for red cells and for platelets, again from lifeblood, but just theoretically speaking, you give red blood cells to people who need blood, so they've got a hemoglobin problem, low hemoglobin anemia, so symptomatic anemia, and your general rule should be transfuse if less than 70, but there are some patient groups where you might want to aim higher, and all of these cutoffs if someone's actively bleeding and you're using the blood as sort of like a resuscitating agent, as opposed to a treating of anemia agent, they're all a little bit different. But platelets, you give to people who've got low platelets, and specifically you give to people who've got low platelets with bone marrow failure, so like a production problem. Things like ITP and TTP and HUS and all of those sorts of things where they've got like an activated consuming of the platelets situation. You don't really help things by giving them platelets. So ITP you treat by immunosuppressing them and giving them IVIG. And things like TTP you treat with plasma exchange, and HUS you treat with supportive care and eculizumab, depending on whether they've got the typical or the atypical version. And all of those are more like consumptive processes. But if you've got someone who's just had recent chemotherapy and their platelet count has dropped very low, or if they've had a stem cell transplant and you're waiting for their bone marrow to start engrafting and producing stuff again, that's the group of patients where you would give platelets to try to stop them from having a spontaneous bleed. Also, you might be in situations where someone who's got a low platelet count that isn't causing them any problems starts to cause them a problem because they've got a bleeding issue, or you need to do a procedure and the platelet count isn't safe to do the procedure. You give fresh frozen plasma to people who need a mixture of clotting factors. And you give cryoprecipitate to people who need fibrinogen. So I chucked the yucky diagram on the right because it's important to understand that the intrinsic pathway and the extrinsic pathway both meet at factor 10. And factor 10's job is basically, once it's activated, to catalyze this prothrombin turning into thrombin. And then thrombin's job is to turn fibrinogen into fibrin. And then you get your clot. So if you don't have fibrinogen, you can't make a clot, even if you've otherwise got a normally working clotting cascade. And I think that that's a thing that a lot of people don't appreciate in the sort of heavily bleeding person. So the reason why you need to think about fibrinogen in bleeding people is because you can kind of like run out of all of your fibrinogen because of the process of trying to stop yourself from bleeding. And then once you've run out of it, even if your clotting cascade is otherwise working, you still can't form clot. And then I've just highlighted in red the factors 9 to 10 that were the prothrombin ones. So those of you who've just started working, you might not have prescribed prothrombin, but that was the previous factor concentrate as that was used as warfarin reversal. It didn't contain 7. Recently, we've changed to using Beriplex, which contains 7. They're otherwise identical. They're dosed the same. You kind of use them the same way, but it's just a different product. Now, that's important because it's got 2, 7, 9, and 10 in it, which reverses warfarin. And so it's mostly used for acutely reversing warfarin if you want to reverse it immediately. If you're happy to just sort of let it improve slowly over time, you can give the person vitamin K and let their INR come down. So that just depends on the situation. Cool. This is from Lifeblood. Lifeblood have tons of very good resources on a range of things. So this is just pointing out that different patient groups have different cutoffs for transfusion. So sort of standard people, they've done studies and they've found no difference if you aim for a hemoglobin above 70 versus like aiming for higher. Cardiac surgery, they've also demonstrated that's not particularly helpful. Elective hip surgeries, not particularly helpful to be like very aggressive. And then even recently, they've found that being overly liberal, even when someone's having acute myocardial infarction, isn't helpful. So basically every time they've studied it, liberal transfusion has not been better than a restricted transfusion strategy. Not addressed in this is people who've got like cirrhosis and variceal bleeding, where it's also very clear that you don't want to over transfuse them because it just causes more bleeding and more problems. So you would aim for 70 in that group as well. Although if they're actively bleeding, it's a little bit more malleable because you're doing sort of fluid resuscitation at the same time. And then for platelet transfusions, this is a very busy slide, but it would have, if I was designing it, I might have made these different colors, making them all red sort of doesn't really draw the eye in. But this top one is specifically talking about trying to prevent people from having a bleed. This middle one is talking about people who are having a bleed. And then this one here is I want to do a procedure on someone that carries a bleeding risk. So the top one, you'll notice that for people who've got severe thrombocytopenia because of not making enough of it, that you shouldn't transfuse them unless it's less than 10 outside of specific situations which are mostly related to acute illness or fever of infections or minor bleeding, where you can bump it up to try to keep their platelets above 20. In people who are bleeding, if they're bleeding and it's not a major bleed or a really dangerous one, you aim somewhere around the 50 mark. And if it's a critical one, you aim around the 100 mark. Critical is traditionally intracranial stuff. And you don't transfuse people with platelets if they're on antiplatelets to try to like reverse the antiplatelet. That doesn't work. So you just go by the cutoffs. And then for these procedures, and I would use these procedure numbers. So I typically go for 50 for a lumbar puncture. So if their platelet count was 50, I was comfortable doing a lumbar puncture. But otherwise it's 50 to 100, depending on the style of surgery that you're doing. All of this is also decided by the person who's doing the procedure as well. So the question in the chat was just asking, what do they mean by AMI? They mean during the acute AMI, like the hospitalization for AMI, not just a person who's got a past history of AMI. And that was specifically, the most recent one was the MINT study. You can look at it if you'd like. So this is just some practical stuff. Again, it's mostly applicable to if you're working a haematology rotation, but it could also come up if you're doing a procedural specialty in the future, like interventional radiology or general surgery or something like that. Those are the sort of thresholds for transfusion of red cells and platelets. Moving on to massive transfusion. In short, it's a patient who needs or is expected to need more than 4 units of red blood cell transfusion within 24 hours. And there's kind of massive transfusions and there's massive transfusions. But for sort of research purposes, you need to make a definition. And that's a reasonably liberal definition. So if you are working somewhere and you're activating a massive transfusion protocol, or it's being called from blood bank to you, the situations might be different. You might have a person who's got a ruptured AAA and you need all of the blood products in the hospital, or a person who started bleeding when you did a lung transplant on them and you need all the product in the hospital, or a big trauma and you need all the product not only in the hospital but also from neighboring hospitals. So that's a massive transfusion. And then you might have people who are just using a decent amount of blood product, but it's not always critical and you don't need all of the blood products in the hospital. And so that's why when you're in a situation like this, it's super important to communicate with the blood bank. Which is mostly so that they can just make sure that they've got all of the stuff that you want when you want it. A lot of people don't appreciate that you need to, well, if fresh frozen plasma is frozen, you can't transfuse things that are frozen. You need to defrost them first. And not every hospital has like a bunch of defrosting sort of water baths. So, for example, one of the hospitals I worked at could only sort of defrost 2 units of FFP at a time, and it takes about 20 minutes to defrost them. So if you're not telling them far enough in advance that you're going to need 6 units of FFP, you're going to get your FFP more slowly than if you told them in advance and they could start defrosting it. So it's mostly about like logistical stuff and making sure that they've actually got enough platelets in the hospital and they've got enough blood and et cetera, et cetera. But ultimately, if you're in a situation where you're the first responder to a massive bleed, it's always Dr. ABCD, and then you ultimately need to do supportive care for them while you transfuse as close to what they're losing as possible. So if they're hosing out all of their blood, they're not just losing red cells, but they're losing all their plasma. So you need to try to replace their plasma as close as possible. So that's why massive transfusions are a mixture of red blood cells, FFP, platelets, and also cryoprecipitate, because each of those things cobbled together in whatever ratio the local sort of hospital has decided gets you close enough to the blood that they're actually losing. For smaller like bleeds, or those like ones where you maybe need 4 or 5 units in the course of 24 hours, but they're not actively bleeding, you don't as much need that sort of 1-to-1-to-1 ratio that they talk about in the literature. I think that is very important not to forget is the fibrinogen, because of stuff that I talked about before. But an additional thing that's very important to remember, and this is more for people who are in like going into critical care or stuff like that, is that your clotting cascade needs enough calcium to work, because calcium's a cofactor for all of it. It needs a normal temperature, otherwise it doesn't work, and it needs a normal pH, otherwise it doesn't work. So if you're resuscitating someone like this, temperature management, pH management, calcium management, all of these things are things that you need to be thinking about and sort of regularly checking. Cool. And then ultimately, if you don't stop the thing that's bleeding, then they'll just keep bleeding. That should be reasonably logical. Going on to some transfusion reactions. So there's lots of different types, and they get categorized by immune and non-immune. So immune being like an immune-mediated problem, non-immune being like a non-immune-mediated problem, like some kind of physical problem. And I don't think that that's that helpful a way to think about them, to be honest with you, because people present with sort of clinical syndromes. I think it's way easier to just think of them as the clinical syndrome. So practically speaking, if you're called to review someone who's having a transfusion reaction, it'll be either they've had a fever, they've had a rash or urticaria, or they've got dyspnea or hypoxia. That's sort of, you also might get called to someone who's like just suddenly become very unwell, and where they might manifest several of these things, but it's going to be something like that. And in fever, you're thinking of, does this person have an infection, either from the blood product or not from the blood product, or are they having an immune-mediated transfusion reaction? In urticaria and rash, you're wondering, have they got a mild allergy versus anaphylaxis? And in dyspnea or hypoxia, you're trying to get a sense of, are they sort of critically unwell with sepsis or whatever, or do they have fluid overload, or do they have one of the immune transfusion reactions that makes you hypoxic? And if you get called about a transfusion reaction, the basic sort of stepwise approach would be stop the transfusion. If they're critically unwell, call a met call or a code or whatever it's called in the state that you work in. Do vital signs, do sort of sensible Dr. ABCD medicine, and then check the product and the ID, and then report the reaction to blood bank. Nursing staff will typically be experienced in the doing of all of this process, so they'll often know where the forms are and even start doing the forms before they've even before you've even finished reviewing the patient. But all of that's important. It's important for the management of them, because if you notice that the wrong thing has been given to the wrong person, the management might be different versus if it is a appropriately matched thing. But also so that there can be like a proper review of the things that led to the reaction, because there's very sort of strict legislated governance requirements for blood products. So as I mentioned, if they've got a fever, what you're trying to figure out is, do they have some kind of mild, non-worrying, probably febrile, non-hemolytic transfusion reaction, which is the one where the recipient is reacting to something inside of the red cells that they've got, something that's leaked through the white cell filter. This is categorized as being they're well, otherwise they've got an isolated fever that's not more than 1.5 degrees from their baseline and not above 39 degrees. And it's the type of one where you pause it, you maybe give them some Panadol, you check how they're going. Well, if they're completely fine, you can retry it again later. If it's anything but that, you're starting to think about, and to be honest with you, you're also thinking about, like, does this person have any signs of sepsis with the in the mild version? It's just that it's reasonably reassuring if they're otherwise well and it's an isolated fever and it gets better once you pause it, and etc. But the question is, do they have sepsis or an acute hemolytic reaction? So in that one, it'll be a higher temperature rise, and they'll be otherwise feeling unwell. It might be chills or rigors or tachypnea, pain, nausea, vomiting. It'll be something. And those ones you'll treat like any other sort of query septic person, with the sort of septic screen stuff, plus minus deciding whether to give them antibiotics. And on the other side, all of the transfusion reaction, blood product checking stuff and filling out the paperwork. This group of people, you would not retest them. So you would just discard the blood products. For dyspnea, really by far the most common one is just someone's got fluid overloaded from the fluid. So someone with a history of heart failure who's older, who just has had a couple of units of blood, which is 500 mils of fluid, and they've just become overloaded, just the same as if you gave them some saline. And in the literature, it's called transfusion-associated circulatory overload, or TACO. These ones you would treat in the same way as you would treat standard overload. So you diurese them. So you could pause it, give them some diuresis, and then restart it if you wanted to. You could also, if you knew that you were giving someone who's prone to getting fluid overloaded several red blood cell transfusions, you could just give them some frusemide sort of in between each of their bags to try to prevent this from happening. If someone becomes like acutely critically unwell, somewhere between 1 and 6 hours after getting a transfusion, when they were fine before it, they might have this rare thing called transfusion-related acute lung injury, which is like an immune-mediated antibodies in the transfusion that react with the recipient and make them get acute respiratory distress syndrome. So similar to any of the other acute respiratory distress syndromes, they get like this really flash diffuse pulmonary edema, become really unwell and have to go to ICU for supportive care. So that's rare, but it's a thing that you should think about, particularly if they've finished the transfusion a few hours ago, but then now they're becoming critically suddenly unwell. They might have Charlie. And then for rash and urticaria, you're thinking if they're otherwise fine and it's just an isolated little bit of itch or a little bit of urticaria, you can pause, give them some antihistamines. If it settles, you can restart it. If it's generalized or they have angioedema, but they don't have hypotension or airway issues where you would call them anaphylaxis, you pause, give them antihistamines, but you wouldn't re-challenge it. And then if you've got proper anaphylaxis, which is defined as the urticaria angioedema with hypotension or the nausea or the vomiting or stuff like that, you pause and you give them adrenaline. You would call them ECFL or a code blue. And you would do a tryptase, which would be evidence of it being anaphylaxis. And the reason why you do IgA levels is because if someone has IgA deficiency, so they don't have their own IgA, they can basically have an anaphylactic reaction to the trace IgA that's left in the blood, because even though it's sort of all spun out, you still get trace amounts of stuff there. So those are some transfusion-related reaction bits of information. And then for anticoagulated person bleeding, I really didn't want to overcomplicate it, because ultimately it boils down to you do your doctor ABCD, you identify where they're bleeding from, and you try to address the cause of that. And then from the point of view of the anticoagulant, you reverse it if you can. So for warfarin, you would give the factor concentrate plus vitamin K. If they're critically bleeding, you also give them FFP to just make sure that they've got enough clotting factors to be able to clot, in a similar vibe to the massive transfusion situation. For dabigatran, there's the specific antidote idarucizumab, which is an antibody that basically binds out the dabigatran, so it stops it from working. Apixaban and rivaroxaban, there's like a failed specific antidote called andexanet alpha, which is very expensive and actually doesn't appear to help. So we don't use that, and actually we basically follow a very similar model for someone who's got major bleeding to warfarin, which is where you give them Beriplex plus minus FFP. For enoxaparin, you can give them protamine, and that reverses about half of the effect of enoxaparin. And then for heparin, you can give them protamine, and that reverses all of the effect of heparin. So that's there's a few more anticoagulants. I wouldn't worry about them, but in general, it's do your basics, give them some kind of reversing, and then if they qualify for a massive transfusion type vibe, don't forget doing things like FFP, checking coags for cryoprecipitate, and all of that sort of stuff. And antiplatelets, I've already mentioned that you don't give platelets to. And a thing that I think that sometimes gets people on this is just not appreciating that they don't have to be catastrophically terribly bleeding for it to be a good idea to just pause their anticoagulant, even if you don't do something to reverse it. And if you've got a person who's going to be undertaking a procedure, following your local hospital guidelines to make sure that you're stopping the anticoagulant at the right time so that they can have their procedure safely is also an important thing to do. Okay. I'm just going to go through a couple of cases and then we can all go. So I'm just going to talk through them. You can put stuff in the chat if you would like, but we've got a 27-year-old woman who's been sent into the ED by her GP with anemia. She's had 12 months of menorrhagia, doesn't have any significant history otherwise. Heart rate is okay, blood pressure is okay, SATs are okay, she's not febrile. You do a full exam and don't find anything. And then you do the investigations on the right. So that's a hemoglobin of 73, a white cells of 5, a platelets of 550. UECs, LFTs, and coags are all okay. Ferritin's very low. Transferrin saturation is very low. And when you do a film, they've got a microcytic hypochromic anemia with mild thrombocytosis. So this is not a particularly difficult one. Have a think about what you think's going on and what you would do about it. Specifically, what if any medications would you prescribe? What if any blood products would you give? So that's the type of thing that you should be asking yourself. And also a useful thing to be thinking in situations like this is what would need to change for me to make a different decision. So like what number would need to be what clinical history would need to be what examination would need to be what, so that you're not just doing it totally vibes based, but you've actually got some kind of understanding of what the metrics are that you're paying attention to. So what I think is going on in this case is that this lady has iron deficiency anemia from menorrhagia. I don't think it's a particularly complicated case. So the what to do about it is that it's a couple of aspects to it. So the first thing you'd be wondering is, do we need to give her a blood transfusion now? Do we need to give her an iron infusion now? Can we just send her away with oral iron, et cetera, et cetera? So those are all the types of questions that you should be asking. And I would say that for someone like this who's otherwise going okay, I would just give them an iron infusion now to replete their iron stores. Probably line them up to get another iron infusion again in like a month's time, to make sure that they've properly got repleted iron stores. And then just let them make their own red blood cells. So she would start making reticulocytes within a couple of days once she's got repleted iron stores to make red cells with. And because she's otherwise going okay, a couple of days is fine to wait. If the hemoglobin was like 50 and she was really symptomatic with it, you could maybe give her a unit of blood and some iron, to try to see if you can get the symptoms to be feeling better. If she was older and like frailer and the anemia was really affecting her function, then you might even transfuse her to like closer to the 80 mark to get her level of function such that she can actually be discharged and function at home while you wait for her bone marrow to be able to start making some stuff. So that's that aspect to it, so that whether you should transfuse or not. Someone in the chat has asked why the platelets are high. Does anyone in the audience know why the platelets are high? I'll leave it with the audience, see if anyone says anything, and then I'll answer at the end. So that's the transfusion bit of it. The iron bit of it, use whatever your hospital tells you to use. So there's Ferinject and then there's Monifer. Ferinject is probably like better tolerated, less infusion reactions and stuff like that, but it might be that your hospital uses Monifer instead. It doesn't really matter what you use as long as you give her some IV iron. And then the other aspect to this case is the managing of the menorrhagia. So she clearly needs to have some kind of management for her menorrhagia so that she's not getting so iron deficient from it, which would probably be sending her back to the GP to talk about, contraceptive pills and etc., or maybe seeing a gynecologist, depending on whether they've tried stuff and failed previously. You could also make an argument in a person like this. I would also probably just take a bleeding history to see if this is just menorrhagia versus menorrhagia plus maybe some indication that she might have an inherited bleeding disorder. So von Willebrand's disease is very common, and one of the ways that it may present is very bad menorrhagia in women. So if she had like a family history of everyone has menorrhagia and everyone bruises really easily, you might do some investigations for von Willebrand's disease, because if you diagnose with von Willebrand's disease, you might do some different things around both the management of her menorrhagia, but also if she's going to have sort of major surgery in the future, you might do some different stuff. But someone without any of that and who's just got some menorrhagia, I would probably just give them some iron, see what happens. So the answer to the thrombocytosis question is that there's a couple of things that can give you a reactive thrombocytosis, so make your platelets go out as a result of something making them go up. So bleeding will do it, infections will do it, major trauma or surgery will do it, and iron deficiency will do it. I don't know why. I'm sure someone knows, but it's certainly not me. But the answer is that it's super common for someone who's got significant iron deficiency anemia to also have a mild thrombocytosis. If you saw the thrombocytosis with without the anemia and it was chronic and it was very high and you found no reason for it, then you might be starting to think about essential thrombocytosis, where there's a myeloproliferative neoplasm stimulating them to make too many platelets, which I think in the chat a couple of people are thinking that might be an option. So yeah, that's Our Lady with iron deficiency anemia. In terms of how much effect one iron infusion has, if you give her 1.5 grams of iron in an iron infusion, you'll get her back to normal stores and she'll go back to not being anemic as long as she's not having really heavy bleeding consistently. Part of the reason why you get her in for another infusion later is so you can make sure that you give her enough iron to fully replete her stores. All right. Case number 2 is a 33-year-old man who's coming in with epistaxis and a rash. He's got no significant medical history, doesn't have any medications, had a cold a couple of weeks ago. When you examine him, you can have iron infusions actually as regularly as you need. So there are some people who have like unfixable GI losses, like you've tried to find the cause and it was a disaster, and scope, gastroscopy didn't show anything, colonoscopy didn't show anything, push enteroscopy didn't show anything, pill cam didn't show anything, but they very clearly have some kind of upper GI or sort of middle GI bleeding. And it's not appropriate to do more invasive stuff. So that group of people, it can be completely fine to just give them iron infusions every few months. That group of people, maybe you might want to put them on oral iron and see how they go. And if they can tolerate the oral iron and the oral iron gets them to the point where they don't become super deficient, then you don't need to do the iron infusions super regularly. But I've definitely met a few people who need regular iron infusions because of GI losses that they were never able to sort of fully fix. Going back to this, so we've got nothing to find on examination. The obs are all fine. There's some blood around his nose. You look inside his mouth, that all looks okay. But this is what the rash looks like. So this is a petechial rash, and you do some investigations which show that hemoglobin's okay, white cells are okay, platelets are very low at 8, UECs are normal, LFTs are normal, INR's 1.2, which is normal, APTT is 25, which is normal, and fibrinogen is 4.5, which is normal. And the blood film, which is important just in case you're kind of looking for signs of leukemia. You're also looking for signs of some of the nastier versions of thrombocytopenia, like those ones I mentioned earlier. So DIC, hemolytic uremic syndrome, and TTP, all of which should have red cell fragmentation on it. So this person's just got isolated thrombocytopenia, everything else looks okay. Some of you may have seen this disease before, some of you may know what this person has, but this is a reasonably classic presentation for the thing that this person has, which I will tell you is ITP, so immune thrombocytopenic purpura, where their immune system, specifically their platelets, are being attacked. Their immune system, specifically antibodies, are attacking platelets and making them be consumed. So this person is noticing that they've not got enough platelets, is trying to pump out more and more of them, but they just keep getting bound by antibody and getting destroyed. This person needs to be treated acutely because their platelet count is so low that it's dangerous. If you had them where they weren't presenting like this, but they were presenting with maybe a little bit of like a nosebleed where they do an FBE at the GP and the platelet count is like 40 or 50, you might do something different in the sense that you might not go as hard on some of the management on the next slide. But for this particular person, you'd probably go reasonably, you'd probably throw most of the stuff that is the acute management of ITP at them, just to stop the risk of having major bleeding. In particular, if someone's got like blood blisters on the inside of their mouth, or they've got any evidence of GI bleeding or things like that, that's quite a significant sign that they're at high risk of bleeding. And so that group of people, they get treated very aggressively. So what we would do about this is we would get good sort of vascular access to take our bloods. We give them 1 milligram per kilogram of prednisolone daily. And then we give them, probably this person, you would give some intravenous immunoglobulin, which you give as 1 gram per kilogram as either 1 or 2 doses. You can kind of give the first dose and see how they respond. And if they respond nicely, you don't need to give the second dose, just so that you're not wasting sort of money and product. And then you send off some investigations to see why this person might be having this. So do they have an autoimmune phenotype like lupus? Have they got an infection driving it like hepatitis or HIV? And then H. pylori is also associated with ITP, and so that's why they get tested for that. In particular, if anyone's got like unexplained cytopenias, you should always send an HIV test on them. So like the person if this person came in and their platelets were 40 or 50, I would definitely make sure that I send an HIV test on them, because that could be their presenting symptom of HIV. And And I'm just showing you what the blood portal looks like. So if you're in a hospital and you've got to organize this for someone, you need to request it from the people who sort of supply it all, which is Lifeblood, the same group of people that have the resources that I've told you are really good. And so they've got to approve someone being allowed to have IVIG. So you log into this blood portal thing, you put all the patient information into it, you say what the disease is, what the criteria are that they meet, and who the supervising sort of consultant is that has approved it, which would be a haematologist if it's a haematological problem, an immunologist if it's an immunological problem, a neurologist, et cetera, et cetera. You don't need me to name all of the specialties that exist. But then what you would do is, once you're approved to give an amount of IVIG, you then go to your local blood bank and say, hey, can we please have this IVIG to give it? So it's like this two-step process of request, like authorization to get the IVIG from the central source, but then you also need to like tell your blood bank that they need to give it to you, and then chart it on whatever sort of your hospital system is to chart it so that the patient actually gets given it. The question, so are there any investigations to confirm ITP? So is there the equivalent of a DAT for hemolytic anemia? No. It's very much a diagnosis, like a circumstantial diagnosis. So if they've got a classic history for it, and they respond classically, so you give them IVIG and it immediately gets better. You give them prednisolone and it's better within a couple of days. That's how you make the diagnosis. In people who are older, or in people who have some other, like they're not responding quite as quickly as you would have thought or whatever, the test that you do is a bone marrow biopsy to check if it looks like there's anything else going on in their bone marrow that would explain it. And so if it's going to look like classic ITP, they'd have lots of megakaryocytes because they've got a stimulated megakaryocytes because the body knows that the platelets are low, but everything else will look okay. But it also may be the first presentation of someone with an acute leukemia or myeloma or something like that. So that's why as people get older, they're more likely to have cancers. As they're younger, you're less likely to have cancers. And that's why they'll often bone marrow people, even if they're reasonably sure that it's a pretty classic ITP, because the sort of pretest probability of them having something else going on is higher. And the other thing that you would consider is other causes of thrombocytopenia. So if someone's got like chronic liver disease or a toxin or something like that, I haven't gone into the entirety of thrombocytopenia here, but for example, if they're hospitalized and have recent heparin exposure, you might be thinking of heparin-induced thrombocytopenia. If they had the red cell changes on the film, then you might be thinking of TTP and HUS. So there's no confirmative one, but there's a lot of circumstantial or ruling out of other pathological causes of, or sort of nasty causes of platelets being low. Hopefully that answers your question. All right, case 3. So we've got a 68-year-old woman who's come in with abdominal pain and distension that's been worsening over the last week, hasn't opened her bowels for the last 3 days, occurs on a background of 6 months of weight loss, lethargy, and altered bowel habits. Got a past history of hypertension on amlodipine, hypercholesterolemia on atorvastatin, and a total hip replacement for OA. They're distended and tender on abdominal examination. Heart rate's a bit high, blood pressure's okay, afebrile sats are okay, rest rate's a little bit up. That's their X-ray, which shows that they've got a bowel obstruction. The FBE is sort of, there's a bunch of stuff that is deranged on the bloods. So just going through it in order, there's an anemia paired with a thrombocytopenia, which makes you worried that they might have one of the processes that's like consuming platelets and smashing up red cells. They've got a mildly elevated urea and creatinine. Their ALT is a bit high and their Billy's 22. And then they've got an elevated INR and a slightly low fibrinogen. So the normal for INR is 1.3 or below, and the normal for fibrinogen is sort of above 2.5 or so. So all of this together points towards someone who is consuming their clotting factors and smashing up their red cells as a result of it. So this would be a reasonably classic set of investigations to make you think about DIC, disseminated intravascular coagulation, where something sets off your clotting cascade, which then makes you consume all your stuff, which then makes clots form in all of your microvasculature, so like in your capillary beds, etc. And then when red cells try to go past, they kind of get smashed up. And so that's why you have the anemia and the thrombocytopenia and the elevated INR and the low fibrinogen, because they're consuming their clotting factors. They're probably also just generally sick, so probably have some pre-renal acute kidney injury from not having good oral intake for the last week. And as to why their LFTs are off, maybe they've got cancer inside of them, who knows? So that's kind of what's going on there. And then what do you want to do about it? Well, you want to get some good access for this person because they're acutely unwell. You want to get a group and hold because you think that it's possible that you might want to transfuse this person at some point in the near future, but you don't need to transfuse them right now because they're not actively bleeding, but they might be going for a major operation. You would want to give them some amount of fluid resuscitation for their acute kidney injury. And you would probably want to give them something for the DIC that you think they're in. So you'd probably give them a unit of FFP and some cryoprecipitate, repeat the coag, see what happens. And at the same time, you're organising a CT, you're talking to the surgeons, you're organising for this person to probably be heading towards theatre once it's safe for them to do so. And then once you've done your initial resuscitation, you would want to be getting some repeat blood tests like an FB UEC coags, probably a VBG, and etc. So the question is why 1 and 5? How do I get those numbers? So in general, you kind of want to be giving like one amount of blood products outside of critical situations, and one amount of FFP is 1 unit, and one amount of cryoprecipitate is 5 units. So 5 units would be like the base amount of cryoprecipitate because it comes in very like small amounts. So that's why you do it for those things. Also, when you're transfusing someone red blood cells, you ideally would transfuse like 1 unit and then assess response rather than automatically prescribing 2 or 3 units. That's a little bit different because it depends on the indication. So for example, if someone's chronically transfused for myelodysplastic syndrome or for thalassemia, know that every time they come in, they need 2 units. Don't give them 1 unit and then wait because that's like wasting their time. But in someone where you're on the wards and they've, meet the transfusion threshold, give them 1 unit, see what happens, as opposed to automatically giving them 2 or 3. All right, second last case. So got a middle-aged man brought in by ambulance after being found by a passerby in the street, barely conscious. The ambos state that there's multiple stab wounds in the chest and the abdomen. He can't give any history. His heart rate's high, blood pressure's low, sats are okay, he's afebrile. He's got stab wounds in his chest and his mid-abdomen. His VBG is bad, so he has a mixed metabolic and respiratory acidosis because his CO2 is high and his bicarb is low. So if he was having a respiratory acidosis, you would expect the CO2 to be high, but the bicarb to be normal or high. If he was having just a metabolic acidosis, you'd expect the bicarb to be low and then him to be getting respiratory compensation with the CO2 being low. So the fact that he's got both of those things sort of in the acid direction means that he's got a respiratory and a metabolic acidosis. And the reason why him, at least a contributor to his metabolic acidosis will be this lactate of 10. I haven't given you enough information for you to figure out exactly what's going on, mostly because I didn't think you'd be interested in doing a technical sort of acidosis exploration. But so what's going on is he's been stabbed and he's having massive hemorrhage and he's getting end organ dysfunction and end organ hypoxemia as a result of that. And you need to, well, not you, but like the people who are managing him need to do a whole bunch of supportive care and figuring out where he's bleeding from and stopping it. So this is one of those ones where it's like all hands on deck, trauma center, notified blood bank, do a massive transfusion, maybe even, they sometimes even do things like think about like ED thoracotomies and stuff like that. So it all gets very complicated, but the basic principle is we need to do resuscitation of him in a Dr. ABCD kind of way using blood products, and then we need to get him to theatre so that they can actually see what's bleeding and stop it. And sometimes what they do is like open things up, just pack things, let things settle, and then come back the next day to do the actual sort of more definitive surgery. So what it would look like is you do a trauma call. Every hospital is different in how they run these things, but you do a trauma call, you'd make sure they're in a resus cubicle. You might even call more of a code blue. It depends on your hospital, but if your hospital, mostly the trauma calls are like not super serious, then maybe in this particular person, you might say a trauma call and a code blue so that you've got the right amount of people there for this person who's almost arrested. You'd make sure you've got very good access. You'd make sure that you've notified blood bank and you're sending off all of the right stuff. You might even request from blood bank to have some uncross-matched O-negative blood to begin with, so that you can get some of the resuscitation going while they do a cross-match. So that's important. And then you will also probably need to do more of a massive transfusion protocol style of approach for this person, where you're starting to think about giving him a decent amount of FFP and sort of cryoprecipitate and maybe some platelets, depending on what the numbers look like and depending on how much blood you need to give him. This kind of person needs to go like straight to theatre and then go to ICU afterwards, where they'll monitor very closely and do sort of frequent bloods, frequent VBGs, etc., etc., etc. So that's that case. And then the last one is a lady who's presenting with fall and confusion. So she was found on the floor by her daughter, came to check on her when she didn't answer her phone in the morning, got a history of AF and a mechanical aortic valve on warfarin, hypertension, type 2 diabetes, usually completely fine. Heart rate okay, blood pressure a bit high, afebrile sats okay. Big bruise on the left side of her face, some bruises on her left arm and leg. She's oriented to person but not place or time, which is not normal for her. She doesn't have any focal neurology on examination. Her pupils are equal and reactive. So the CT shows an acute subdural hemorrhage with some mass effect. So the subdural hemorrhage is pushing the tentorium across and sort of making the ventricles all squished. So that's not super unexpected, given the history of big head strike, big contusion, bit confused on warfarin. FBE's okay, UECs are okay, LFTs are okay. Coags, so her INR target is 2.5 to 3.5. So her INR is within her target range, but it is obviously very important. So the way that I like to think about reversing anticoagulation when in various different situations is, would you want to start a person on an anticoagulant if you were in the current situation? Because sometimes people are like, oh, there's only a small bit of blood and INR is not super elevated, etc., etc. But it's like if someone had only a very small intracranial hemorrhage, like a small traumatic subarachnoid, would you commence them on anticoagulation at that time point? And the answer is probably no. Well, I certainly hope the answer is no. And so you really should be thinking about reversing the anticoagulant for any amount of intracranial bleeding, or really any amount of worrying bleeding of any kind. So she needs to have reversal of her warfarin using the warfarin reversal protocol that you've got locally. She needs to be discussed with the neurosurgery team, and you need to figure out what to do from there. So we need good access. We need to get approval to give her the Beriplex. We need to give her the Beriplex and also give her some vitamin K so that she can make her own clotting factors normally once the Beriplex is worn off. We need to refer to neurosurgery to assess whether it's appropriate for her to go to theatre. Based on her age, you might think not, but she's independent, fully functional. She's, got a reversible thing. And it certainly would be appropriate for her to be in a hospital where at least neurosurgery was there to operate on her if things deteriorated, even if they didn't decide to operate it at time zero. I would recheck her coags after just to make sure that everything looks okay, and then just use calf compressors for VTE prophylaxis, because obviously you don't want to run VTE prophylaxis with an acute intracranial hemorrhage. And then the things that you'll need to decide down the track that will totally depend on what happens with her, like does she have surgery versus not, does she get better versus not, does her CT look stable or not, is when's the right time to recommence anticoagulation down the track, and when you do recommence it, what's the right way to recommence it. So until then, she's going to have a risk of having a stroke, and you just need to accept that. She's got a risk of having a stroke because she can't be anticoagulated because she's got bleeding in her brain, which she'll die from if you don't stop it. So you just need to accept that. And as long as everyone is very informed and in making sort of intelligent decisions around it, it's totally fine. With regard to the right timing to recommence anticoagulation, it's very variable depending on the type of bleed and the sort of circumstances and why they need the anticoagulation in the first place. There's no sort of set rules, but in general, when you've got a significant intracranial hemorrhage, you want to be off therapeutic anticoagulation for probably at least the first several weeks or even up to a month. And then the right way to recommence it when the time comes might be just to get her onto DVT prophylaxis first, see how things are going, and then slowly escalate it from there. But you would probably do it with the neurosurgeons and discussion with haematology. So case recap. So case one, not everyone with anemia needs blood, and you can replace iron and let them figure it out for themselves. Case two is not everyone with low platelets needs platelets. And if you're not sure how to order something that you've never had to order before, just ask someone. In case three, don't forget fibrinogen. And then if someone might need a procedure in the future, it's very useful to predict that and to plan ahead. Case four, blood bank can be extremely helpful if you're in a need a bunch of blood products situation. Just talk to them and they'll be extremely helpful. And then in case five, you really need to be reversing anticoagulants in people who've got major bleeding, even if it's in range. And then don't just automatically assume that old people are not for operative management. It's a combination of age, frailty, the procedure itself, and the downsides of not doing the procedure. And then the overall summary is just the blood products themselves. Try to understand what's in them, which will then help you understand when to give them. For bleeding people, try to fix their coagulation cascade, stop things that would interfere with it, and then identify why they're bleeding and stop it. And then for transfusion reactions, do the basics and use the resources available to you. So if you go onto Lifeblood, you can get like a transfusion reaction little card, or you can just look it up at the time when you're experiencing reviewing a patient with a transfusion reaction to remind you of this stuff. So that is that. Here are some resources. There's lots of good sort of blood banking resources available. Lifeblood, BloodSafe, eLearning Australia, National Blood Authority. Those are all places that have like little sort of pamphlet-y style things that can be very helpful for you. So that's that.
Thanks so much, Taz. I'm just popping the feedback link in the chat again, but please, if anybody has any questions, feel free to pop it in the chat.
Yeah, you can ask whatever you like. No worries to the various people saying thank you. Someone has asked, does giving a blood transfusion suppress bone marrow from making its own red blood cells for 1 to 2 months? I've heard this, but not sure why or if it's true. No. In short, your bone marrow responds to erythropoietin production, and erythropoietin production is the combination of a couple of things like, you've got to have renal function, but mostly it responds to like an oxygen tension thing, so like an oxygen delivery thing. So just giving someone a single blood transfusion, all that means is that they've got extra red cells there that are getting them back to not even back to a normal level of red cells, but back to like a very low level of red cells. And then the body should still then get the appropriate amount of stimulus, theoretically, to want to make new red cells. Because red cells don't have an infinite lifespan. They only last a month or so.